Well, hello, everybody, and welcome to PMNCH's Adolescent Health and Wellbeing webinar series, where today we're talking about what the numbers say, understanding data on adolescent health and well-being. My name is Miriam Sabin, and I am your moderator today. I'm the accountability focal point at the Partnership for Maternal, Newborn, and Child Health. And as you know, a key part of accountability is ensuring that we have strong, quality, reliable, and timely data so that we can understand how better to improve programs and as well as funding and a number of the key areas that are needed for civil society, governments, and all stakeholders to have a say in health responses. So I wanted to also just share with you briefly that, we have heard a lot as the adolescent and youth constituency at PMNCH that young people often talk about wanting to understand more about data. And we hear this in several different ways, really. So in general, in terms of, what is the global or the regional or your country's status of data, health-related data, but in particular on adolescents and young people. And the good news, and you'll hear some of this, is that things have been improving slowly over time. And there's more that we can say now than we've been able to say, but there are also a number of areas that are still really critical gap areas, and you'll hear about that as well. We also hear a lot about young people and adolescents wondering where best to access data. So what is available? Um, is it available, and how can we all access it? And that's a different question, whether we're talking about at the global level, the regional, and at your national levels. And we want to try to address that for you as well, because having those data is, knowledge and power. We also want to hear from you about what you see are some of the gaps and the challenges, what you're struggling with in terms of whether it's understanding where the data come from, what they mean, what's the current situation, where to access them, and how best to advocate using those to improve adolescent health and well-being programs. So I will leave it at that and just let you know, remind you all that we are live tweeting this event. For those of you on Twitter, please use the hashtag EWECYouth, and we will be really happy to be able to retweet what you're doing and hear from you as well in the text boxes where you'll be able to ask questions. So just to tell you briefly about the flow of the session today, we will have our first speaker, Regina Guthold from WHO, who will be providing you a strong overview. It'll be about 20 minutes from WHO on the status of adolescent health and adolescent health data. We'll then take a couple of questions, then we'll move into our other speakers, and I'll introduce them as we go through the program, who will speak briefly about their key areas. And then we'll have time for a discussion where we will take your questions and then wrap up. So one thing we will be doing, just so you're aware, is that we will be showing slides where they're available. We'll also be recording this session so that it will be available to others who couldn't attend today. So thank you very much. And if you have any specific questions or questions related to technology, you can put those in the chat box as well, and we will try to be able to address those as we go through. So I think with that, we'll get started. And as you can see, we're going to start with Regina Guthold's presentation, which we're moving to in 1 second. And I'd like to remind everybody again as we're waiting to please just mute. We're hearing some background noise that might affect the other people listening. So here you can see here that Regina will be talking about challenges and action on data among adolescents. And Dr. Guthold is from the Maternal Child Adolescent Health and Aging Department at WHO Geneva. So Regina, over to you.
Thank you very much, Miriam. Can you hear me okay, Miriam?
I can, it's perfect.
Okay, great. So let me start then. Thanks for the introduction. Next slide, please. So this is a summary of the presentation. I will be talking about main types of adolescent health data and where the data come from. I will be talking about where can you find information on adolescent health. I will give you an example. I will provide some overview of global and regional adolescent health statistics around population, around mortality, what adolescents die from, around diseases and risk factors for diseases. I will also be giving an example on how WHO uses adolescent health data and how we are trying to improve adolescent health data. Next slide, please. The types of adolescent health data, and there are more than what is shown on the slide. These are just examples of main types. We have data on adolescent population, for example, the percentage of adolescents living in a specific country. We have data on mortality of adolescents, and that means all-cause mortality, how many adolescents die in each country or region, and what they die from. What are the main diseases that adolescents affect? What would be the risk factors or protective factors? For example, what would be the percentage of tobacco use among adolescents in a specific country? Data around laws and policies. For example, what laws exist in a specific country that are relevant for adolescent health? Data around the health system, data on schools, for example, how many hours of physical education happens in different schools, in different countries, and data around environmental and social factors. Next slide, please. Now, where do adolescent health data come from? There are many, many different sources. For example, a lot of the adolescent health data is collected through surveys. For example, surveys that are done in households or in schools, or online surveys, youth consultations. A lot of data around births and mortality comes from civil registration, registries that register births, deaths, and causes of deaths, disease registers, but also surveys on policies and laws that are relevant for adolescent health. It is very important to note that these data are mostly collected in countries, in schools, in communities, in health facilities. They are mostly collected in the countries. And WHO often uses these data to produce global or regional or even country estimates. But all of the estimates that WHO produces are based on actual country data, data that's collected in countries, communities, schools, and so on. Next slide, please. Now, where to find adolescent health information? Recently, WHO has put together a data portal that displays data for maternal, newborn, child, and adolescent health. So that's one big source of information on adolescent health. There is a whole series of pages and information and data on adolescent health, including data on demographics, population data, and so on, mortality, causes of death, data on morbidity, data on risk factors, and on policies. Within this data portal, there is also a function where you can download adolescent health country profiles for all of the 194 WHO member states. So there is a function where you can access the country profiles. You click on a country and you get a 2-page document with the most important adolescent health information for a specific country. Next slide, please. Now I would like to present some actual data or some estimated data around adolescent health. These are population pyramids. You're probably familiar with these. They have the number of actual population of people on the x-axis and the age on the y-axis. The upper charts are examples for Africa from 1950 to 2050 estimated, and the lower charts are for Asia, the development of the population in Asia from 1950 to 2050. The adolescent ages, WHO defines adolescents as those aged 10 to 19. You can see the third and fourth bars from the bottom, that would represent the adolescent ages. So as you can see, in Africa, there are still lots of adolescents as compared to very old people. In Asia, on the other hand, if you look at those pyramids, by 2050, it will no longer really be a pyramid. It will have a shape. There are less adolescents compared to older people. That means that the population is aging. And that is the case not only in Asia, but in most other regions of the world as well, except for Africa at the moment. Overall, there are 16% of the global population that are adolescents aged 10 to 19. 16% of the global population. But as I said, this varies a lot for different regions and different countries. Next slide, please. This is data, global data on mortality by sex and age. So on the x-axis, you have years 2000 to 2016, and on the y-axis you have death rate. That is the number of deaths per 100,000 population. The different lines represent the different gender and the age groups. So the dotted line, the one that starts highest in red, is the death rate for females aged 5 to 9, and the blue one, males aged 5 to 9. I put those, they're not adolescents, they're older children, but just for comparison, look at the decline over time. They have declined from about 160 per 100,000 in the year 2000 to less than 100, both of them, by the year 2016. The other lines that you see, the lines that are not dotted at all, are older adolescents. Blue again for males, red for females. You can see the males started at about the same point, but the decline was not as rapid as for the younger ages. Females of that age group 15 to 19 are a little bit lower than males, but again, we don't see the decline we would like to see in overall mortality. The death rate of 3 age groups is lowest in 10 to 14-year-old adolescents, but again, we don't see the declines that we would like to see. Overall, more than 1,100,000 adolescents died in the year 2016. And as I said, we have not seen great reductions in adolescent deaths since the year 2000, which is a worry. Next slide, please. This represents adolescent deaths by WHO region. And here you see the two different age groups. The younger ages, 10 to 14 years old, in yellow. The older adolescents, 15 to 19 years old, in red. And you see that the older adolescents have a higher death rate in all of the regions as compared to the younger adolescents. You also see that the greatest death rate is in Africa as compared to the other regions, the lowest in Europe, Western Pacific. So the adolescent death rates vary a lot by region and by age. Next slide, please. Now looking at what causes it, on the left you see the death rates among male adolescents in blue. On the right you see the death rate among the causes of deaths among females, the two different age groups for the year 2016. You see that the bars are longer for the older ages, meaning they have a higher death rate per 100,000 than the younger age groups. The most important cause of death among male adolescents in both 10 to 14-year-olds is road injury. Interpersonal violence is an important cause of death for older adolescent males, as well as self-harm. HIV and drowning are also important causes. If you look over to females, most important cause of death among those aged 15 to 19 are maternal conditions, self-harm, and also road injury. Next slide, please. Now again, this is the causes of health issues that are not dead, again in the year 2016. So we have just looked at deaths and causes of deaths. Now we're looking at things that cause health issues, health burden among adolescents, but that are not dead. So the main cause of health issues or health burden among male adolescents are childhood behavioral disorders in both younger and older males. We have iron deficiency anemia that's showing up quite a bit. Younger males, younger females and older females, an important cause of the non-deadly health burden among adolescents. We have depressive disorders that show up. We have skin diseases that show up in all of the age groups and both sexes, as well as anxiety disorders, and we have migraine. So overall, you see multiple things that are mental health issues, including childhood behavioral disorders, depressive disorders, anxiety disorders, autism. So there is a lot of health burden that is caused by mental disorders. Next slide, please. I also wanted to talk a little bit about the risk factors that cause diseases. So this is an example for a risk factor where we have comparable estimates on the prevalence of overweight among adolescents aged 10 to 19. So this shows the different WHO regions against the prevalence, the percentage of overweight. The blue bars are males, red is females, and green is both sexes. As you can see, the highest percentages of overweight are seen in the region of the Americas among girls and boys. Western Pacific has a relatively high percentage among boys, lower among girls, and Europe is also relatively high. The lowest percentages we see in Africa and Southeast Asia. But globally, as you see, for both boys and girl adolescents, the prevalence of overweight is over 15%. I have listed the top 10 countries of the 191 with data, the countries with the highest prevalence in the world. Those are Nauru, Cook Islands, Niue, Marshall Islands, Tuvalu, Tonga, Kiribati, Samoa, and Micronesia. As you can see, all of those are in the Pacific. These are Pacific islands, and there is a huge rate adolescents and in all ages actually over there. Next slide, please. Another example for a risk factor for disease is insufficient physical activity. Adolescents and children are supposed to do 1 hour moderate to vigorous physical activity per day. That's the current WHO recommendation to get a health benefit from physical activity. The percentage of adolescents that meet this recommendation is very low. The graph shows actually the percentage of those that do not meet this recommendation. As you can see on the far right of the graph, this is the global percentage. It's around 80%, almost 80 in boys, more than 80 in girls, of adolescents that do not meet this current recommendation of 1 hour of activity a day. There is not much variation across the regions at all. You can see that Southeast Asia is the region with the lowest percentages, but still pretty high, over 70%. Again, I've listed the top 10 countries of 120 with data on the right. I will not read them out, but you will have the slides. So this is another area of worry, the high percentages of physical inactivity among adolescents. Next slide, please. And these are examples of other risk factors where I pulled data from the global school-based student health survey. So that's a school survey that's done mostly in lower income countries, lower and middle income countries. This is a combined set of data from the years 2001 to 2017. And this survey is done among those aged 13 to 15, or some countries do 13 to 17 in the more recent years. You can see the indicators in the first row. So 4 indicators are listed. The percentage of adolescents that attempted suicide, the percentage that were involved in a fight, the percentage that were bullied, and the percentage of those that were seriously injured. Below you can see the number of countries with data. So not all countries globally would have data on these indicators. So just to give you an idea of how many countries we are talking about. And for all of these indicators, I have listed top 10 countries. And at the bottom, you see the median of all countries. Now, the median is that value that separates the whole population into 2 halves. So if the median, for example, for the percent of those attempted suicide is 13%, that means half the countries are below 13% and the other half is above 13%. 13% is a lot. Those adolescents that attempted suicide, that's the median, but the values go up as high as 34% in Solomon Islands. Involved fight, where the median is 37%, so half the countries are below and half the countries are above, but again, it goes up very high, up to over 70% in Tokelau and Tuvalu. Percent that were bullied, median was 31, but again, as high as 70% in Samoa and 70% in Egypt. And then lastly, those that were seriously injured among almost 100 countries, the median was 43%, with values going up as high as 83 in Samoa or Ghana, for example. Next slide, please. Using data. Now, we do collect data for one reason. We want to use the data to drive policy, to change things. We are collecting data to then actually look at the data and try to change things to the better. One example of using data is the WHO Global Accelerated Act of Adolescence with the name AHA. AHA is a guidance document for countries that actually uses data to develop policies and programs that will improve adolescent health. The approach that AHA uses is to actually look at the data, at the adolescent data that a country has, and also at existing policies and programs that try to improve adolescent health. And with that kind of landscape analysis, a country sets priorities based on the data. The data shows where the problems are, so the priorities are set based on the data. Gaps are identified. Data gaps, because oftentimes countries have data gaps, areas where they don't actually know what's going on. And then interventions are implemented based on those priorities, involving ministries, NGOs, civil society, young people, schools, and communities. That is one example of how WHO promotes the use of adolescent health data. Next slide, please. Now, how do we try to improve adolescent health data and fill gaps? The current landscape of adolescent health measurement is that there are many different initiatives with advice on how and what to measure within adolescent health. So different initiatives recommend different indicators on what type of data to collect. We oftentimes have inconsistent recommendations from initiatives. We have different approaches to measurement. We sometimes have duplication of efforts, and yet we do have important gaps in measurement. That is the current situation. Lots of different initiatives that try to help with adolescent health measurement, that try to make recommendations, but actually there is a lot of inconsistency out there. So next slide. There is a new initiative called the Global Action for Measurement of Adolescent Health. It's the GAMMA initiative that tries to address this problem. The GAMMA is a group of experts and young people that advises WHO on adolescent health measurement. The group was established by WHO, but is heavily supported by lots of other UN agencies, such as UNAIDS, UNESCO, UNFPA, UNICEF, UN Women, the World Bank Group, the World Food Programme. The group or the initiative aims to improve and harmonize adolescent health measurement globally. The group wants to define a set of core indicators for adolescent health measurement. What are the most important things to measure among adolescents and how to measure them? That's the goal of the group. More information on this group is on the GAMMA website below. Next slide, please. In summary, you have seen that there are many different types of adolescent health data from many different sources. The WHO data portal on maternal, newborn, child, and adolescent health tries to bring the adolescent health data together, and you have the link there. We have also seen that the main global causes of adolescent health deaths, and they are estimated, are road injury, self-harm, and interpersonal violence. The main global causes of adolescent disease are iron deficiency anemia, skin diseases, and mental disorders. There are many, many risk factors for health that are important in adolescence, and I have only presented a few. The AHA approach is an approach that is trying to use data to improve adolescent health in countries. And the Gamma group works on improving adolescent health measurement. Next slide, please. Thank you very much for your attention.
Thank you very much, Regina, for that excellent, really informative presentation. We'd like to now just open it for a couple of questions, and I can tell you that we have a few that have been put in the comment box already. One question was, how do causes of disease vary according to regions? So maybe you just a little bit more about that. And then sort of a second follow-up question to that was asked about also how do these causes of disease vary by socioeconomic status? Would you be able to respond to that? Thank
Thank you very much for these questions. Um, just to let you know that I have provided links to the resources for these data that I've used for the causes of disease burden. It's all listed there for different regions and different, as well as country profiles. But just to give you a flavor, the causes of disease quite a bit across the different regions, but we do see some things showing up in pretty much all regions. And that is, for example, iron deficiency anemia that's showing up as an important cause of disease in many regions, as well as skin diseases and mental disorders, the different types of mental disorders. There is not as much variation across regions as there is for adolescent deaths. The same is true for socioeconomic status.
Thank you, Regina. And I think we have time for one more question, important question that's been asked, and that is so what is the disease burden like for adolescents living in conflict regions? And how is that classified? And I think this is something we're hearing more and more about lately, and also in terms of how we're able to gather data in conflict zones and how this perhaps affects the work that you do in looking at the global picture. Over to you.
Thank you very much. That is a very important and actually quite difficult question. There is not much data on conflict regions. The causes of disease and causes of death are quite different in conflict regions as compared to other regions. What we do see, some graphs, for example, on mortality is that it heavily influences, for example, the rates of all-cause mortality. We do see, if we look at trends over time, we do see these spikes in the trends that the overall all-cause mortality goes up and then down again if there is a conflict in some area. So that is very interesting, but it is a difficult area of work and very difficult to get data for those regions. But nonetheless, we must make an effort to collect more.
Okay, thank you very much. We're going to move on now to our next speaker, who is Giorgi Pkhakadze, and he is with the UN Secretary General's Independent Accountability Panel. So, Giorgi, over to you, please.
Thank you for the opportunity to share in the accountability panel's report. Actually, recently, IP published a report in 2017 on transformative accountability for adolescents. And when they come up of today's webinar, it's very much to the work what we did in 2007. The speaker mentioned that we have a lot of data available. However, the challenges are very much there. So if you can move to my first slide, please. So when talking about transformative accountability for adolescents, so we to our 2017 report, we focus on the 6 main recommendations, and I would like to focus more on the issue of today's webinar when talking about the data. So when we talk about make adolescents visible and measure what matters, we see that more than half data indicators related to children under 18 is available, poor, or limited. And as also previously mentioned, there is a lot of data collection tools available. However, no any just one point agreed space where all this data can be validated and can be clearly measured. Many gaps in disaggregated by sex, age, and disability, overall including the young adolescents. And here we again go back to the different organizations. They're using different type of data collection. Sometimes they're using data such they don't mention the age, but they mention age brackets. For example, they'll put 4, 5, sometimes 6 years bracket as a one. Sometimes it's very difficult to measure age, and for adolescents, even 1 year makes a significant difference. Despite data gaps, opportunities exist to better leverage the data that is available, and including, for example, collecting data generated by the citizens, including the adolescents. And this is widely used at the moment, and this is very positive move on the worldwide. However, it's not everywhere. To raise awareness and action about gaps in the data, in the services, and discrimination to access to the health services. This is the key, because we launched our operation when we pay our report that access to the essential services, health services for adolescents, is a challenge in countries and almost in all regions. And we are not talking about the challenges adolescents face in the conflict areas, as my colleagues mentioned also previously, that when we look at the conflict, in some cases we don't have data at all, and if data is collected, the quality of data is a big question. Also see that demand exclude adolescents to become priority, address gaps, and discrimination. Discrimination, its issue is also related to the gender. Sometimes we have some services for the girls, and sometimes the services for the boys are missing, or vice versa. So when we talk about the exclusion, we talk about as a gender, but also for the general demand what the adolescents really need. And for our framework of the accountability, we look to our report not only for monitoring and review, but we also been very strong on looking at remedy and act. Have a second slide, please. Thank you. When we talk about the data, we know that a lot of data is collected, and as a second recommendation, it was that we consider adaptation of the adolescent health and well-being data, well-being index. So we see that as it's already mentioned, that a lot of data is collected worldwide, in the global level, regional, and the country, and even the community level, even through the different advocacy groups. However, we have a great index, And as a result, we have a misuse of the resources, or sometimes we collect too much data. Sometimes we just collect the same set of information. And we also see that even several UN agencies, they're collecting exactly set of data. And as I said, with nowadays, when we have a really limited resources available, to mobilize this resource and put them in one particular point, it will be much more practical for make sure that it will be much more sustainable, and it will help us to have a much more strategic positioning adolescents for the SDG and beyond. Also, we believe that index could draw on existing data, and its components should reflect the holistic, multi-sectoral approach needed to the adolescent needs and rights. Because we believe that if we talk about adolescent health, we have to be very strong to make sure that adolescent needs and rights are equally represented. It does not have to officially form part of intergovernmental framework. Yes, it could serve as a powerful advocacy tool, not only on the global level, but it could be very strong advocacy tool on regional, country, and in the community level. So when the community groups will have this indicator to show that this is the issue what adolescents have, and this is the global indicators, and this is and how we can move forward. So this is just a I consider to implement and to adopt adolescent health and well-being data. Can I have a next, please? And use of data, monitoring and accountability. This is the biggest challenge what we are talking about. So when talking about reporting and use of disaggregated data on adolescent health, development and right across should be ensured global, regional, and national monitoring process, which is not always easy. All UN reports and monitoring should disaggregate data by age and sex as well. When you talk about including citizens in, participation, the citizens hearing and social accountability platform should be convened during the health assemblies, during the World Health Assembly, and all other global and events. And at the national and subnational levels, communities and young people should be empowered to participate in the policy and budgetary formulation and programs reviewed, and to identify accountability gaps and priority action for follow-up. We know that if budget is not allocated, we cannot have proper policies in place. Policy without budget, they are not strong enough. And in many places, they just stay on the paper. That's why it's very important that adolescents will participate, meaningfully participate in all these processes and make sure that they also be part of the budgetary formulation and program review. However, we also have to mention that all the data issues, what was mentioned, that we do have limited data. However, it doesn't mean that things are not moving forward. We said that, as from WHO mentioned, there are organizations now extensively work to improve, to integrate, and there are some positive moves around. However, we strongly believe that better improvement is needed, and the better coordination is needed in all levels to make sure that we will be able to get adequate and sustainable tool which will be used not only in the global level but very important on the community level. So this is my very short presentation on the accountability and adolescence, and of course I strongly advise all our participants, can we have a last slide please, to check our website, and you'll have opportunity to see our report in much more in detail with the annexes and indexes, and you'll have opportunity to discover the way how an independent accountability panel works to make sure that we address the very important need. And I want to add the last point, that because of the issues of humanitarian setting by this speaker, that I going to work next report on accountability in a humanitarian setting. So everybody who will be interested to contribute will be really happy to get your inputs and information. So this is a short presentation from my end.
Thank you very much, Giorgi, for that great presentation. We're going to move now directly over to Lucy Fagan, who is part of the UN Major Group for Children and Youth and the Commonwealth Youth Health Network. So Lucy, I have a question for you. As a young person connecting the data to advocacy, can you elaborate on why young people should be engaged in discussions around data, and how can this be useful in advocacy efforts? Over.
Great, thank you, Miriam. So this is something I'm really passionate about, and I'm really delighted actually that we're all able to come together and discuss data in this webinar, not just as an add-on, but actually as a focus. That said, I think I've only got a short time to provide my comments, so I'll try and keep it short and snappy. Data should be a critical part of advocacy for us as young people, especially when it comes to the monitoring and the follow-up and review of policies. Without accessible, open, and, as others have mentioned, disaggregated data, we can't build a full picture of what's happening with adolescents and how it may differ from government commitments. Engaging with data can take a number of forms, and I want to particularly emphasise the role of young people in A, advocating for more and better data about the issues important to adolescents and young people, and B, generating, selecting, and sharing data and information, which in turn can drive greater youth-led advocacy and accountability, that importantly is built on local experience. So just touching on both of those briefly, I want to give you some examples of how young people can get involved in conversations around data and use this to inform their efforts. So first, let's talk a little bit about why young people should be involved in advocating for better data. I'm sure many of you have heard the phrase, we cannot manage what we cannot measure. So I've heard that one so many times over the years. If we do not collect data on the health and well-being of adolescents, how can we know where progress is being made and where policy and programs are falling short? Understanding who the most excluded groups are, where they are, and what stands in their way, depriving them of good health and well-being across their life. It's one of the most challenging but important parts of actually improving their lives. I think for adolescents, it can sometimes feel quite difficult to engage in conversations around data. It's technical, it's complex, and you can worry sometimes you're not the expert. I certainly feel like that. But we need to also recognise that youth advocates bring really critical expertise to the table when we're talking about data. Youth advocate, you know the needs of your peers, you know where the gaps are, whether it be mental health, or something else entirely. You know why these things are important for the health outcomes of young people, and particularly what groups are at risk of being left behind in your community. It should be what steers the conversation of what is measured and how it's measured. So take a steer from youth advocates in South Africa who are pushing for better data on mental health to try and understand actually what are the lived realities of young people, or the efforts of young advocates working on NCGs who have been really trying to drive advocacy around the SDG 3.4 indicator around premature mortality from non-communicable diseases to make sure that it actually recognises all deaths under 70 years old, rather than just 30 to 70, which is what it is at the minute. Because we know that adolescence isn't just about risk factors, but that everyday young people are dying from things like uncontrolled diabetes, from chronic diseases, and from childhood cancers. Filling those data gaps is really hard, but by engaging with governments and other key stakeholders on the data, we can start to make some progress and measure what matters. This recognition of the importance that young advocates can play in conversations around data is starting to be seen at multiple levels. So in her presentation earlier, Regina mentioned how the Gamma Advisory Group is sort of advising and engaging with WHO and other UN partners on how to improve adolescent health management. 4 young people in that group, representing both advocates and young researchers, were able to bring in key insights from different regions. I'm one of those people. I'm also a co-chair of the group. And one of the things we established from the beginning is that we're really keen that Gamma's work is informed by the priorities of adolescents and young people themselves. And we recently launched a short survey to gather insights on this. I'm really pleased to say we've now extended the deadline for this, so it's going to be running until mid-September. And we're also going to be adding some new language options, including French, Spanish, and Chinese. So those of you who are already members of the PMNCH Adolescent and Youth Constituency may have already received a link to this, but we can also share after the webinar. So please do share widely amongst your networks. We're looking forward to updating you on our findings in due course and tell you a little bit more how this input is actually influencing adolescent measurement. And then finally, moving on to more familiar territory, I also wanted to highlight the importance of using data for youth-led advocacy and accountability. So data is a really important tool in your advocacy arsenal. Understanding what data exists, what it actually represents, and using it to inform your advocacy will help maximise your impact. And the data you need can come from a variety of sources at the local, the national, and the global levels. Your country's Ministry of Health will probably be able to provide information that hopefully is open and accessible on different health indicators. But there are also other sources such as the ones shared by WHO in the first presentation. But just always make sure you also know its limitations. Data can sometimes be very contested and it's not always easily comparable. Identifying this data and using it to support your advocacy messages and to galvanise action can be really useful. Also, always remember it's about how you communicate it. Interpret the data and to provide the so what, the underlying stories and what their implications are for policy and programme. It would be great if this was sufficient. So identify the data, explain the problem or the opportunity, and galvanise greater action. However, as I mentioned at the beginning, we know that these official indicators may not go far enough to measure the progress for adolescent health. So I think just to touch on the fact that young people are also well placed to track progress within their local communities, where they often have access to and are able to provide bits of data and information that national monitoring and reporting might miss. So you as a youth advocate can engage with service providers and youth-led organisations to gather local data and to engage young people directly through consultations, through live reporting and budget tracking and much more. And you can use this in many ways. You can do community scorecards, you can lead community-led validation exercises, checking lived experience and community realities against the data that you've collected. Community scorecards is a really great advocacy tool. And I'm really keen to hear about how you are collecting and using data in your own advocacy. So hopefully we'll have a time for a good discussion on this. And then so finally a few points to leave you with. 1, advocate for the data that matters to adolescent and young people's health. 2, interpret the data and share it to enhance accountability on key adolescent health commitments. If it doesn't exist, why not find creative ways of collecting your own? And then finally, this is something we can all play a part in. So we need to train and equip the next generation of young advocates to use data and evidence in their advocacy efforts. The potential is huge. You just think about the way young people are already engaging on things like social media, but we all need support to get there. Data is complex, and we need to be empowered to use it. So thank you very much.
Thank you very much, Lucy, for your presentation. I want to quickly remind everybody that although we're not taking questions until following our next presenter, please feel free to go ahead and put your questions into the chat box now, and then we'll be able to move right into the discussion after that. So we're going to move right now to our next speaker, Yemurai Nyoni, who is from the Children's Investment Fund Foundation, or CIF. And Yemurai, I have a question for you too. So from your experience working as a young person, particularly with donors, what are concrete examples of how community-based data can drive accountability? And what is the added value of such initiatives, particularly at country level? Thanks, and over to you.
Thank you. And, also thanks to Lucy for sharing a lot of insights into how youth engagement and making use of data creates an impact. So I'll just share based on 2 aspects. One, work with the Children's Investment Fund Foundation and some of the resourcing we provide to youth-led organizations, networks, and coalitions, as well as my own personal experience as a youth activist. And I'm particularly interested and will refer to using data in restrictive advocacy settings, normally where there's a risky political environment. And the challenge, that I want to speak to is that a lot of government-owned data is not publicized well enough in some settings, and is at times biased to specific narrative, and civil society, youth being part of that, have a key role in sharing data and gathering additional data to validate or challenge existing data, especially around adolescent health. In some contexts, as we discuss, complicated issues, especially around sexual and reproductive health, it is filled with a lot of challenges in terms of how to communicate effectively and how to speak truth to power, etc. So some of what we've been doing first is supporting youth networks and coalitions. Coalitions networks have a particular strength in their ability to aggregate the concerns of young people and also act power in being able to engage with systems, governments, etc., almost on equal footing. But also they're an important tool in terms of sharing data and also collecting alternative data, as it were, in the case, for example, of shadow reports. And that is the approach we've adopted in our support of work in Kenya. So, for example, in Kenya, we supported a collective called G-Activate, who worked alongside government and other entities in the 2017 election with the aim of being able to gather the insights of youth and present an evidence-driven case for the kinds of priorities that young people have. And they use that tool to hold political parties to account before heading into an election. And they are using that post as well to gather data on the state of Kenyan youth and also to engage directly with the office bearers now, who also committed to supporting the manifesto and documentation they provided. I remember also, I'll give some personal examples here, is I'm from Zimbabwe, and at some point we had a sexual reproductive health education strategy that was meant to be rolled out. We had the data, we knew what was required, and the strategy had to come out urgently. So what we had to do with a couple of colleagues was surface the data on the need to accelerate the release of the strategy, and then hold the Minister of Education to task. So because we had pushed for transparency of certain processes in government, we had access to data. So ensuring transparency of data and access of activists and youth organizations to data is important to make sure that where there are any bottlenecks and processes stop before they're completed, or services or policies are not fully acted on. Young people and citizens who are meant to be addressed by these policies, then I'm to be able to use that information. Also, from some of the work we've been doing regionally and globally, networks and coalitions, you will note most times that government delegations, either to the UN or the African Union in the case of Africa, oftentimes what the foreign missions push forward is somewhat different to domestic policy. So there's bandwagoning actively at global and regional levels according to regional blocks, etc. And so one of the things we tried to do was to push for youth activists to be aware of the policies that governments have on, and to use that information when they then were part of government delegations to hold foreign missions to account, to make sure that there's consistency in terms of local policy, in terms of the statistics we have at local level on what is a priority, and then what is negotiated at a higher level. Then there are, smaller use cases in terms of informing budget advocacy, also, in terms of explaining observed performance, so the role of youth in qualitative data, so that when government policy and strategy are reviewed, it is easy to explain why, it's the story behind the numbers, by getting adolescents and young themselves to be able to unpack issues behind the data we collect. And then in the cases of contested issues, it's also important to gather evidence to counter opposition, to provide an evidence-based case. Although we all know that evidence, they say we're in a post-truth era, evidence is not the best or most accurate way of challenging or putting forward arguments, but by all means, it's one of the most important tools we have, and that's what we use to counter opposition. Some of the lessons we've learned as I wind up is the importance of youth organizations and networks to work closely with governments. Governments, in some settings are moving everywhere, actually move to control what type of data is gathered and also how it's published, some stricter than others. And so it really works well when the drive to gather data to be used for accountability is done alongside partners and parties that need to be held accountable in future. So working closely with government for us has been critical, getting the necessary approvals, working with the different departments, and making sure that publications, done very closely or in close link with the relevant government departments. The second lesson we've learned is that shadow reports or parallel reports face the continual challenge of legitimacy. So they are important, in providing an alternative narrative. But the question now is, do they have the influence? Do they actually move governments to see things in a different way and actually see that as a route for for them to be more accountable to their citizens? We've seen cases where shadow reports actually elicit a clamp down or pushback from government, with some people in some settings getting arrested because of putting out these alternative narratives. And that's a challenge to think about. Think of youth activists and organizations in the context of defending human rights. So that also increases risks. So in some countries, that the risk premium of that kind of work has gone a lot higher. The last bit is what I spoke about in terms of the importance of networks and coalitions. So I know it's not all encompassing, and it's relatively subjective in terms of the experience we've had as a foundation, and I've had myself too in this space. But there are many outlets, to make use of important data, because it needs to be used, to take action on. And it'll be interesting to hear also, suggestions from the participants in the webinar in terms of how they use it, in restrictive settings, results that they've had. Thank you.
Thanks very much, Yemurai. That's great. I think what we're going to do as we look through the questions that we have already, and others collect their thoughts and put down their questions, I'd like to go to all of the speakers now, and in the order that you spoke, and just ask you to elaborate on your one really sort of key message, what you'd like everybody to take away from your presentation, just very briefly in 30 seconds or so. So Regina, to start with you.
Okay, thank you, Miriam. I would like to have two take-home messages, please. One is that don't take health estimates as a fact. Remember, as I said in my presentation, health estimates, if they're from WHO or if they are from some other institution, they are based on actual data that's collected in countries, in communities, in schools. So if there is poor quality data coming from countries, estimates are of poor quality. So estimates are based on country data, and they are only as good as the underlying country data. Keep that in mind when you interpret health estimates. That's my one message. The other message is that we need to remember that data are being collected to be used. There is a reason for data collection. We collect data because we want to improve adolescent health. We need to remember that, and we need to use the data that are collected to improve adolescent health. So we need to promote and advocate for the use of data. Thank you. That's my two messages.
Thank you very much, and thank you for two messages. Absolutely. So now we will move to Giorgi, please, for your message. Thanks, or messages.
It's a bit too. I feel we focus on that to ensure that all adolescents receive essential health services and their rights are uphold, it's important to have reliable, disaggregated, and timely data to understand where progress is made and where gaps are. Because with the lack of these key points actually makes difficult to forward and do adequate policy decisions. And also, as a colleague mentioned, I agree that likewise, as much data as important, true impact is in the use of the data, empowering communities and young people and adults with data to participate in policy, program reviews, and priority set, including budget, to call out gaps with the left behind and what redress and action should be taken to ensure health for adolescents. This is two key messages what I want to share with the colleagues.
Thank you very much. And now on to you, Lucy. Over to you.
Brilliant. So I'm just coming off mute, but I think my key takeaway actually from listening to the other speakers is just how many ways young people can get involved around data and the appetite from partners to make that happen. You know, Yemurai spoke about the key role that young advocates and youth-led networks can play in advancing and collecting data. And then you hear from, you know, WHO and IAP about, you know, the importance of this and the steps they are taking to make sure that young people are empowered to use that data. So I think there's some real bright light on the horizon about how we engage with this. And then I think the second point, and I alluded to this in my presentation, but that we should become more comfortable with talking about data, about using data, but also remembering that it's one part of the story.
Great, thanks. And Yemurai.
Yeah, so I think for me, it'd just be two key takeaways. One, just to reiterate, the importance of protecting our work as youth advocates by working closely with government and getting the necessary approval so that at least, you know, in the years that will come, we'll still be able to do our work in our different settings. And the second part is just to continue to note the difference between access and influence. Well, accessing data does not necessarily mean that that data will influence decisions in the way that it could or should. So just making good use of available platforms and getting in contact with influential departments, etc., so that that data doesn't waste away, but it's actually used to influence change.
Okay, thanks very much. And maybe I'll just kick things off quickly by asking you, Yemurai, a follow-up to that is, what would you suggest for youth who might be, living in hard to reach community areas, who may have trouble accessing information or accessing information online? And this could come from some of your personal experiences in this. But what are some thoughts about how, sort of the most vulnerable or disenfranchised youth in the population can, try to get maybe not just LinkedIn a bit, but also to advocate for some change, at their level? Thanks.
Thank you. I think that worked. We did this in Zimbabwe, following on from the successful examples from the Adolescent Youth Alliance, which is a program run by UNFPA. But we set up a multi-sectoral network. A multi-sectoral, it included direct representation of youth from populations that were deemed vulnerable. And by providing an access point for different sectors and young people in different settings and ensuring representation, it helped us make sure in our engagement with government, ministries of health, education, etc., to find ways to make sure they have access to information, they have access to, the attendant services. Also, it helped us be able to support and build the capacity of organizations that represent marginalized or vulnerable groups. And it worked to the extent which we were able to push more rigorously, change legislation in terms of age of testing around HIV, and what I spoke about, sexual reproductive health education, making sure that services would be decentralized to the maximum extent possible, as expressed by young people in the face of government. So for me, again, it is the power of networks and ensuring that they are multi-sectoral, and that in our work, our support to these networks, we also build their capacity. If I'm a young person within a vulnerable setting, the assumption we had was young people have some access point, whether you're in school or you're out of school, whether you're living on the streets, etc. They are touch points. They are organizations or individuals working in that space that then become the conduits of that information, and that also support representation of.
That's great. Thanks, Yemurai. And without, hopefully you won't feel I'm focusing too much on you, but we got a great question also related to your presentation, and I think we'll just stick with you and ask that now. So the question was, could you elaborate a bit on the youth-led quality data that you mentioned? Thanks.
Yes, so the example I mentioned was not necessarily youth-led, but was referring to youth getting involved in the collection of qualitative data to explain observed performance. So, for example, ministries of health with support mostly from the World Health Organization, like Zimbabwe right now, they're having a midterm review of the National Health Strategy, and one of the strands or the themes they have is explaining of performance alongside a lot of other. And in that context, they're working with civil society organizations that work closely with service organizations that provide services, so that they are able to interview beneficiaries or population groups in the areas in which these services are provided. So youth CSOs have a key role to play in providing that kind of data. So there's been a big drive in terms of providing youth-friendly services. This has been a global effort to make sure that services are accessible, and that different standards as according to young needs. Is and has been young people who have, for example, client visits, etc., being able to assess, the quality of service delivery and feed that information upwards. There are things which are quantitative in terms of number of, it could be number of staff, available, etc. But then ultimately, what we want is for the experience of the young person to measure up to expectations that they have when they get to a health facility. So these are some of the examples. So I'll encourage the participant who asked the question to also check up on, for example, some of the work around youth-friendly service provision, and to see, examples of how young people have been working to assess the quality of health services and the methods that have been used to collect that kind of data.
Okay, thanks very much. So we have a bit of a twist on what we were just talking about with the next question, and this question was directed to any of the speakers. What are the effective strategies being employed by the networks or organizations that you represent for involving adolescents in data creation and dissemination? Who would like to tackle that question for us? Perhaps Lucy.
I can come in on that. So it does depend a little bit on the age of the adolescent. But for example, for older adolescents, involving them in training of trainers exercises to support them around understanding data, understanding where the gaps are, and supporting them to be able to engage in sort of community consultations and help facilitate those has been quite an effective way. I think it's really putting in some of the time at the beginning to really support and educate adolescents on actually, data and why it is important. And for younger adolescents, it might be about consulting them. For older adolescents, often they are keen to be engaged and to actually help kind of lead that charge. I mean, I know one of the questions on the group chat was about what tools can be used. And I think there are a variety of different tools that are developed depending on the purpose. So sometimes, I've come across a youth organisation in Trinidad that have used mobile apps to, ask young people to feedback if they see, a healthcare facility that's closed, or there's other opportunities to get young people out there surveying and engaging in sort of consultation exercises with their community. So there are many different ways, and obviously the adolescent age group is also quite a wide age group, so that there are different ways. But I think really helping them understand how data can be gathered, but also really empowering them to understand the data. So I think young people have a really critical role, I think, in curating the data. So actually, when you're gathering this data, when you're starting to interpret and understand what it means, young people can start to communicate that and connect and share that. And accountability, you have youth-led accountability, but actually it is also just communities. And the more we can share some of this data and this information, the more we can push that accountability upwards.
That's great, thanks. And I just wonder, Regina, to the last question that Lucy mentioned, and this will be our last question. I wondered if you had any suggestions for any useful tools for data collection that local NGOs could potentially use in implementation, or if you have just a suggestion or some thoughts on that. Thanks.
Thank you, Miriam. I must say most of the tools that WHO uses are more for like national level and not so much local level. However, having said that, we are currently starting to explore the use of tools that have originally been developed for national level at subnational and local level. Specifically, I'm talking about the GSHS, the Global School-Based Student Health Survey, that has originally been developed to capture a national picture of the risk factor situation regarding NCDs among school-going adolescents. But now we are actually proposing to use this tool more locally in cities, in selected schools of selected cities, to do local surveys that represent a local picture. And we are then promoting the use of the data collected that way directly in the schools. So again, then that's where adolescents come in. They will then actually look at their data, understand their data, interpret their data, and think about things that they could put in place locally to change things. Unfortunately, I don't have a real example yet because this is all just starting, but I thought that's number one, a tool, and number two, an example of how to involve adolescents in understanding, interpreting, and using data.
Okay, thanks a lot. And I'm seeing here, before we go to the wrap up, that there's someone on the line named Danielle who would like to say something. Go ahead.
Thank you very much. Can you hear me well?
You're a little faint. Perhaps if you can get closer to your mic.
Yes. Is this better?
A little bit better, yeah.
Okay. So I wanted to say something. My name is Daniel Tobon Garcia. I currently work with IPPF, the Western Hemisphere region, but I come from the youth movement before, and I just had two things to say. I know that in the past, the coalition called the Pact. We're working on a web-based platform or an app where young people could gather information regarding youth-friendly services and CSC in the community. Maybe if Mimi is there, she could maybe give a little bit more information if she has it. So that's one thing that was going on and in charge of the pact. And I wanted to share another kind of platform or initiative led by the Stanford University. It's called Our Voice, Citizen Science for Health Equity. Is not specifically focused on adolescent health, but it does contain an application or an instrument where young people can collect data on situations in daily life that affect their health. And the methodology that they propose leads them not only to gather information, but to analyze it, to present it to decision makers, and do accountability with it. The project is called Our Voice, Citizen Science for Health Equity, and I just wanted to share that. Thank you very much.
Thanks a lot. Mimi is on the line. Mimi is our adolescent and youth focal point here at the partnership. I just wanted to see, Mimi, if you had anything you wanted to add to that or not. Thanks.
Yes, thanks. Can you hear me? I just wanted to, I just wanted to mention that, the Danielle is referring to is Act 2030, and it was supported, well, at the time I had started it with UNAIDS and in collaboration with IPPF. So I think for people to find out more information, you can just check out the website. Google Act 2030. And yeah, you should find out more information there. For anyone else who's interested in learning more about PMNCH's work around adolescent health and well-being, you reach out to me via the pmnch.ayc@gmail.com. I'll post that in the chat box as well. We are happy to promote, youth-led initiatives, and particularly around data collection and advocacy and accountability. And I know Miriam is going to shortly walk through some of the resources that we have available. Over from my side.
Okay, thanks a lot. So I think we're going to move to wrap up now, and then I'll mention some of the resources again. Really, I'm just going to share a few thoughts that I had in listening to what others said and based on some of the questions that were asked. I think my first thought is really also to remind us, and I need to remind myself of this also at times, absolutely, that data are not necessarily numbers. So by sometimes just using the word data, it definitely can sound very intimidating, very maybe even non-transparent. But data can just simply be a data point, can be the voice of, a young woman speaking somewhere about something that happened to her. And you can use qualitative data and qualitative responses. And of course, you all know this already, but sometimes, this really is what makes the difference, that makes a policy change. It's a human voice or a human face on something that will change the way people have previously thought about an issue. So I definitely wanted to underscore that. The other thing that really struck me, which Regina mentioned, and also the others, but in particular, what you showed, Regina, on the other health outcomes, the mental health issues that are profoundly affecting people, and in all regions around the globe for adolescents and youth. And we're not tackling that issue because we've tended to work so much in silos, in health silos by specific diseases. And of course, because mental health is stigmatized and accessing those services, self-stigma on ourselves to do that. And so, as well with the road injuries, it led me to think about working with infrastructure and other parts of government, whether it comes to better lighting, other types of preventative measures that need to be done. I'm not hearing enough about this, at least where we sit, and I think for me it's definitely a reminder we need to do a better job of looking at some of the priorities that were raised here and bringing in these other sectors to address them. Because what we don't want is, we're putting all our effort, and thankfully so, into reducing, and we are reducing, neonatal, infant, child, and maternal deaths. and that's coming down slowly over time. But we don't want to then forget about the child after age 5 and have them get to an older point in their lives just to die from a preventable cause. Giorgi, I think we really heard your clear message about missing data, and that this can vary by country, it varies by indicator, it varies also by sector. Sometimes we'll have great information in terms of health, and then in other areas we don't have anything for some of those SDGs. So it's a complicated area as well in terms of conflict and fragile settings, which we heard about, which brings its own challenges, but it needs to be done and it needs to be addressed in a better way than it has been. Lucy, you've talked a lot about getting involved in youth-led uh, data. Um, and I think, you're a living example of this, sitting on this WHO and multi-agency gamma working group. So you're a role model for being able to do this. You've done this at the global level, so it can be done as well. Yemurai, you've clearly exemplified that as well. So it was really inspirational to hear that. And then I think lastly, Yemurai, some of what stood out for me, in addition to the qualitative data, is that, there's so much going on that we don't necessarily hear about because adolescents and youth might not be publishing in these peer-reviewed journals or might not be, and are not well represented at the global level in terms of your voices. We have a long way to go on that, but that there is a tremendous amount being done to gather information, to do community monitoring, work at the community level, to work with governments, and at great personal risk in some cases, particularly for vulnerable and key populations, youth who struggle with, their lives on the line or being involved in activities that may be illegal in their countries. And we have to remember this. And I think lastly, um, I would just say that, uh, you know, us folks here, speaking for myself, us old folks, are not as adept at using what I think you all are able to do now and just take over and do. We're able to see Greta Thunberg in the middle of the ocean now, know where her boat is as she's sailing rapidly towards the U.S. climate change talks at the UN General Assembly, tweeting from the middle of the ocean, engaging people, having a voice. It all can be done. And so I hope today you feel that we've tried to represent what you're doing. We hope you've learned something. I think we've all learned a lot from you. And please do get in touch with Mimi. Um, and you can also get in touch with us. She's listed it in the chat box. Also through Twitter. We're happy to do that as well to follow up on some of these conversations. Okay, so I think we just have one small piece just to remind you again about the resources you can see on the slide there. Some of what Regina has worked at this maternal child and adolescent data portal, which is really cool and new because it allows you to be able to go in by your country and pull up key information that you can use for advocacy. I also wanted to remind you about the IAP's Transformative Accountability for Adolescents report, which came out in 2017, which you can also use to advocate based on the recommendations they've made for how we can improve the lives, health, and well-being of adolescents. And then the Advocating for Change for Adolescents toolkit for young people, which has been a PMNCH product, which I think it sounds like would be very useful to those of you who asked about tools on the chat, and to remind you about the consensus statement on meaningful youth engagement, which currently has 230 plus endorsements to date. And this is PMNCH in collaboration with FP 2020 and the International Youth Alliance for Family Planning. So please, please do take a look at that. We'd love to be able to get more endorsements on these key recommendations. And the links for these resources will be shared with all of you registered participants. So with that, we'd like to thanks very much. Thank you very much for your participation and inputs, and we'll close the session. Thank you. And if you're still there, ladies and gentlemen,